We need to balance the needs of the moment versus the needs of the unforeseeable feature. Particularly now, faced with a pandemic, there is no manual on this or any class in architecture school or most schools for that matter that teaches you how to get through it and address the needs of the people you serve in the unusual circumstances we find ourselves in. Yet we need to solve the challenges of creating a safer place. Many have asked about the thoughts on how we need to move forward designing the built and healthcare environment with respect to COVID-19. Our second panel is on the time to rethink healthcare architecture and infrastructure. May I call upon architect Manu Malhotra, who will be moderating this session, to come up on the stage. Our second panel comprises of the subject matter experts, Dr. R. Chandrasekhar, who is the chairman, IGBC Healthcare, and he is a former architect from Ministry of Health. Dr. Alok Roy, who is the chairman and managing director, Medica Synergy Private Limited. Dr. Architect Shamit Manchanda, who is the chief healthcare architect, Manchanda Associates. Dr. Gautam Khanna, CEO and chairman, CEO Hinduja Hospital and chairman of FICCI Health Services Committee. Naresh Duble, head marketing and continuous improvement at Knauf Ceiling Solutions. R. Bhagat Singh, lead specialist product management, commercial air conditioning division and at Blue Star India Limited. Manu, he is the director and chairman of RSMS Architects, and he brings over 2 decades of experience in business development, design development, project management, and programming in healthcare. So Manu, the floor is yours.
Good afternoon, everyone. I would like to take this opportunity to thank ITP for actually organizing such a distinguished panel to discuss one of the most relevant subjects today, which is rethinking the healthcare architecture and infrastructure. I would actually start with Dr. Khanna. Why don't we actually go ahead and introduce ourselves a little bit, and then we take the discussion forward.
So I am, by the way, firstly, thanks to ITP for giving me the honorary degree of a doctor. I'm not a doctor. So I'm an engineer and an MBA kind of a person, regular guy. So I run Hinduja Hospitals, and I've been the CEO of Hinduja Hospital for 8 years plus. Before that, I have worked in the industry for more than 24 years. So, and in addition to my role there, I also chair the FICCI Health Services Committee, and I'm also the president of Associations of Hospital in Mumbai. So thank you for inviting me here. Look forward to the discussion.
Yeah, taking cue from my friend, I do thank ITP. I think we from Blue Star, we continue to associate with ITP for all the years. And after a break of 2 years, I think we are having a physical session. That's very good. And myself, Bhagat Singh, I am taking care of the product management in the HVAC systems, representing Blue Star. Of course, I am also a member of the related committees like Rama and ISHRE, and we have continuous discussions there and taking it forward. I am also a member of BE's Chiller Labeling Program Committee, and I have about 30 years of experience both in India and abroad. Probably we will try to share some of the knowledge what we have in this. Thank you.
Good afternoon, everyone. In fact, very thankful to from the virtual to the reality is the ITP. I am Dr. Chandrasekhar. I am a former chief architect with the Ministry of Health, Government of India. In fact, more in charge of looking after the PMSSY, that is Pradhan Mantri Swasthya Suraksha Yojana. We are setting up of all aims like institution and medical colleges. And presently I am with the World Bank and also the chairperson for the Indian Green Building Council for setting up a healthcare rating system, and visiting professor, London South Bank University. And my specialization is the medical architecture. In fact, I am the first PhD in the country in the field of medical architecture, which I try and promote that healthcare architecture is very specialized subject, where a comprehensive approach is to be done. And being a part of the hospital administrator, so what I do is I also teach planning, designing to guest faculty as a AIMS, and right now AIMS Jammu has come up with a joint program of IIT Jammu, IIM Jammu and AIMS Jammu together, and I am a faculty in that in the AIMS Jammu. Thank you.
Yeah, thanks. So myself is Naresh, and I thank each one of you for being here. So this is an awesome moment. This is my first physical event after, I think many of you are also here for the first time in a physical event. Knauf Group globally is a German group, has taken over Armstrong, which is 160-year-old company. I've been working since right beginning of Armstrong in this country, 20 years back. I'm completing 20 years and 10 years focusing on healthcare. Done some research work around sound and acoustics. Sir has also guided me for a lot of ASIC's AIMS construction and work. So I have some real pleasure of working with the creator, the god, the architects, and the people who really execute the physical reality, the contractors, CPWDs and government and owners. So looking forward to really connect and understand how do we take our hospital to our next level where we can make it AI ready. All those things which we heard in the first session can we really implement in our building.
Dr. Roy.
Namaskar. My name is Dr. Alok Roy. I'm by profession a doctor and trying to run a hospital in Calcutta. And that's it. I serve people.
We need to introduce him. He's the chairman of Medica Group of Hospitals. He's the former chair of FICCI Health Services. He's been instrumental in setting up very large hospitals in the country like Fortis and so on. I can go on and on, but I'll stop here.
Good afternoon, everybody. My name is Shamit Manchanda. I'm an architect. We run a healthcare consultancy firm, Manchanda Associates. We primarily do healthcare and hospital-related projects only, both in the private sector as well as in the government, ranging from Medanta Ganganagar to Apollo Cradle in Greater Noida to Nizam Shura Medical Sciences Accreditation at Hyderabad, to a couple of projects that we're doing in Sikkim at the moment. So that's the basic introduction for my healthcare side. Thank you.
Great, Shamit, thanks. So to set the tone for the discussion, on the subject, I would start with how the hospitals have been designed over the last 2 decades. Some of the basic principles, most of the stakeholders have always been talking about future-proofing the design in terms of, regulatory norms, the changes in ground coverages, FSI, related to machinery and technology in diagnostics and treatment area. But nobody ever talked about the surge demand which came in due to the pandemic. The other things, most of the hospitals were designing for non-communicable diseases, but this was the first time we encountered a situation wherein the communicable disease pattern came into picture because of the pandemic, and here we were not only supposed to save the life of the patients, but also the caregivers. Some of the basic fundamental principles of healthcare design, like segregation of traffic, which is between patients, visitors, staff, doctors, and services. Here we had a subcategory in the patient category itself this time around, which challenged the way the hospitals need to be designed going forward. The surge demand actually also led to a situation where the same infrastructure was used for more and more patients and inflow, which resulted in hospitals, each facility reacting to it in a different manner. Putting the same infrastructure, single room converted to a double room, waiting spaces, corridors. Even in a city like Delhi NCR, we have seen that the corridors were filled up with beds, which led to a lot of egress challenges from fire and life safety perspective. Electrical systems were overstretched, and same was with the medical gas pipeline systems. Having said this, I'm sure with all the experts here, we can actually discuss how each one of you in your kind of setup reacted to this and what are the way forwards, we would suggest for the projects. So I'll start with Dr. Chandrasekhar. You have been associated with both private and government institutes, and also have been instrumental in setting up some COVID centers. What do you think should be our approach towards future preparedness in terms of more pandemics coming in or similar situations? And how do you address the demand of instant demand in making changes in the existing facilities?
Thank you, Manu. In fact, I'll put it in a two-way, because being in the government at the policy level as well as executing things at the ground, if I see it at macro level, always infrastructure is a key. Whenever they say how much it is going to cost, building kitna lagega, how much square feet, what is the kind of a facilities, so this is how it starts. So at the macro level, what has happened, last year Prime Minister already launched National Digital Health Infrastructure Mission. Now that infrastructure mission, basically COVID has taught us number of things. Out of that, one thing which we all know, what crumbled most is the diagnostic. So he said, why can't we have a surveillance through diagnosis, through the networking? So that is where the digitization is used. And for that, setting up at a block level and also keeping a different, the CHC and PHC level where the wellness, health and wellness centers were set up. Now, for any setting up, we always say the money required for infrastructure, he said IT based. IT based means there should be a minimal investment in the infrastructure. And central government has taken certain share also, and accordingly this is being executed and it has been on. Why? That is how the preparedness has to come. So diagnostic surveillance is one of the main key factor. Then also, why can't we have EOPD or discharge or admission, etc., whatever the number of procedure, and finally the e-governance. These kind of methodologies were thought of when National Digital Health Mission was also being conceived. When it was all into the pipeline, COVID actually put it in a very rapid mode, and that is how we are all into digitization. Today, even a fruit vendor, I can pay him digital. To that much extent which we have achieved, that is due to COVID. When I come to the micro level, when e-Sanjeevani or EOPD or tele-consultation, everything is happening, why should everyone should crowd around into the government hospital or any hospital? Though in the private, we come only with the appointment, but in the government, it used to be a crowd. In AIMS, it used to be around 12 to 15,000 footprint per day in OPD. It was such a huge. Now, everything has gone into digitization and very minimal come on a walk-in basis, otherwise everything is on formation. Because of that, what has happened? The waiting area has reduced. That means the area coverage of the infrastructure gets reduced. Now we want touchless parameter, how to go about. And similarly, Indo-UK Institute of Health came up with a concept when Prime Minister went and signed an agreement with this thing. They said, screen everybody at the district level and only the people who need to come to hospital can come, which is really needing hospitalization. That means wellness center is going to be the strength. And I being a part of, not only now I am advising number of states for setting up their medical college and establishment. So they are all onto the same mode. Then the question came in, the manpower. So that also has gone into the E mode in training and methodology. So this is the way now at the macro and micro level, we are trying to manage that how minimal infrastructure construction with the optimal utilization. And today, just now in the prior session, even the last question was, how can be a home care? And particularly we have seen, since I guide some of the PhD students and all, they have also given some feedback saying that in an ICU, maximum 14 days, 12 to 14 days, after that a person has to have a sustenance. Instead of that, why can't we prepare that ICU at home care so that the patient who is at that critical area, he is also recovering fast. So these kind of a thing has developed because of the COVID. We could get into the infrastructure style has changed. It is not the same way what we used to build the hospital. Now, in the hospital segment, generally we always compare government with private, that the OPD area is always larger in the government segment, and the private, you compensate with private rooms, so your IPD area is large. Overall, the total area remains the same. Now the scenario is, we are squeezing, and because of the technology being advanced and touchless parameter, because everybody is aware that this kind of a pandemic is not that one, it has given a warning and every time it can be. Second thing which we learned, our people will, expert will throw light on that, is air quality. Up till now, we were only knowledgeable about ventilation, pressurization, filtration. HEPA filter, best, that is it. Filtration, trapping the pathogen, but it is not killing. So ultraviolet germicidal irradiation, or what we call it UVGI and photohydroionization, these are the killer that you have to kill the pathogen. So that air quality, now people are more concerned even in their own in-house. And there also, people bring in lot of air purifier, and when you bring in air purifier, you have to shut down the door and windows to make it effective. Then the CO2 level goes high. Then the person doesn't know how to have the air changes. So such challenges are now being addressed. This is the impact of post-COVID, and that is where we have started giving this thing. This is just, I am putting it across to set the ball rolling so that everybody will share the experience in the similar line. Thank you.
And I mean, beyond pandemic, what are the evidence-based design, related stuff which you think should be adopted?
See, evidence-based design is what we call it connect with nature. I'll give you just one example. Amitabh Bachchan, during his Kaun Banega Karodpati, somebody asked him a question that, sir, that poetry which you are telling, can you recite? He said, before that I'll tell you on what circumstances I have written that poetry. He said, when I was injured and admitted in Breach Candy Hospital in that coolie shooting. Breach Candy Hospital, a lot of people may be knowing, it is near the seashore in Mumbai. The person, he said that my bed position was behind my window, there is a beautiful sea, my head was in this side. They said, "Arey, ye bed to ghuma do jara, let me enjoy the sea." And that inspired him to give the writing this poetry. The same way, connecting with nature is a great healer. And evidence-based design, you all are using number of colors and specialities and great daylighting. Daylight brings in lot of life. Lot of hospital I have seen now also. Inside the people are in a area where they don't know whether it is raining outside or whether it is a sunshine. Even to an extent, the researchers has gone, how best is the east side light versus the west side light, how the average length of stay and the lesser medication has happened because of that. So evidence-based design has a great, great impact, and connecting with nature is very, very important. And now being in the IGBC chair, I also feel that these are also saves energy, and you will not switch on the unnecessary light when you have a daylighting. That's what in short.
Dr. Roy, coming to you, personally, I've been interacting with you from the last 3 decades. My first interaction I still remember was at Fortis Noida. And ever since then, you have moved on and setting up your own facilities, operating them at Medica. With you, I would like to take the discussion forward on the softer aspects of the infrastructure. That is, how did you address the workflow in terms of your staff movement inside the facilities? What changes you did in the existing setup when the surge actually happened, and you being involved in a lot of designs as well yourself. So what do you think would be the programmatic change, space program changes that would happen going forward for whatever facilities you decide to build or others decide to build?
So I just share some experiences. One good thing of growing old that you have a lot of experiences and you don't mind talking about it. So when the COVID hit, I had some 350 patients in a hospital, and I have a very bad habit of going and seeing all of them and their faces every day, against the wishes of my board and management that why are you doing, you are above 60, why are you going there? But just as a habit, go around, walk around, see the property. So I met one girl, very young girl, around 25, 27, 28, around that, bitterly crying next to a patient. I said, what happened, beta? Why are you crying? Is something wrong with you? I think it happened. That was a time when everybody was wearing a PPE, face covered, face fogged. She says, I'm laughing. She says that, sir, last half an hour at this patient, I've been giving him passive leg movement therapy. And just now nurse comes and tells me, the patient died 1 hour back. Can't you see the screen? It's flat. So then half an hour, she gave him a passive leg movement and patient had died. Half the staff standing outside hysterically laughing, and half the staff standing outside crying with her. So that is a story of medical architecture. Whoever builds a hospital, half the people will like it, half the people will not like it. And the problem with whichever hospital you walk in, whoever built it whenever he built it, 10 years later, other than fixed spots like bathroom and the lift, entire hospital has changed completely. Am I right or wrong, Manu?
Yeah, true.
That is story of medical architecture. So it's a very dynamic field. What Mr. Chandrasekhar had said, it moves so fast. Things change so. We in our hospital, most of our hospital, had some 10 positive pressure and 10 negative pressure. Suddenly the entire hospital became a negative pressure. How do you convert a hospital to negative pressure? All the blue stars and all that, they came and it had to be done not in a month or a year, it had to be done in 24 hours, 48 hours. That was the demand, that was the need. So what we have realized, that health architecture is very, very interdependent on its functionality, staff and technology. These three are the huge hallmark, the bucket of architecture. The manpower, staff, their ability to deliver. So you need to know them, how they are going to deliver, what they are going to deliver. If nursing station is here and pharmacy store is there, she will run 100 times just to give medicine to one patient. So that is staff satisfaction and staff movement and control. Second is that technology. And third is that how do we quickly change our hospital into, that pandemic has taught us, that the ability to transform the hospital based on the need. Yesterday the Berger Paint had a fire. I had 50% burn patients coming to us, and we're not a burn hospital. Now what do you do? They all need a positive pressure, not negative pressure. My entire hospital was tuned to negative pressure. So we had to quickly, now how do we make a negative positive? So, what is emerging very clearly, that if you can give us a flexibility of space, flexibility of functionality, flexibility of ensuring that the infection control don't go beyond control, then you are part of it. So the architect has to be a doctor as well.
So we'll take this discussion, forward with Bhagat, in terms of how we can quickly adapt to the, positive and negative pressures, same room, whether there is a possibility of any human errors there or not. Dr. Alok, you also talked about digital and, technology, and I know that you have been very tech savvy yourself since a long, long time. So what are your views on digital health, artificial intelligence for reporting, and what kind of changes that would bring into the healthcare facilities?
Yeah.
Boss, that's the only way forward. There's no other way forward. If you ask me that there are three ways, which one you will choose? I will say probably left, right, center. But digital, whether it's an app-based, you can't think of life without digital. Your entire life is in the mobile phone.
Yep.
Your bank is here, your passwords are here, your hospital is here, your records are here, your
All your
travels are
documents
here.
are here.
Huh?
DigiLocker has done a great thing. All your documents
Everything
are
is here. So there is no option. Now, sooner, see, I would like to tell everybody sitting here, there is no sane gentleman who can build a hospital with his money and double it in next 20 years. He can't. Gautam will agree with me. There's no money in the healthcare. Whatever anybody may say, there is not enough money to duplicate your facilities. So first time you build it because you are young and you have a lot of dynamism, you beg, borrow, steal some time and build a hospital. Then to sustain it, you need to spend a lot of money, and then to earn enough to build a 500-bed hospital, next to impossible. Now what happens? That the biggest casualty in that was IT. When we started hospitals, I'm an old bandicoot. When I started hospital first time, way back in 85, 86, with the Birla Heart Hospital in Calcutta, which we built with 11 crore. It was a lot of money. Now 11 crore, you don't even buy a diagnostic system in your hospital. So the investment in the IT was least. Today, if, say 5 years back, the IT system became very expensive. 4 crore, 5 crore. I was told yesterday, Max has spent 100 crores. I fell from my chair. I said, 100 crore my father has not seen to spend in IT. Fortunately, with the grace of God, now the technology is becoming cheaper and cheaper and cheaper. Yeah. And the care is becoming easier and easier. Our ability to reach tele-ICU, tele-health, not very expensive. The consultation, the having all the reports on app, consulting the doctors on app, WhatsApp, which is free. A lot of free technology is coming in. Mr. Manu, we have no option but to adopt it, and God is kind, becoming cheaper. So that's the only way left, there's nothing left. Unless you go in the direction, better you shut your shop and go.
Yeah, I think I totally agree with you. You know, when I remember, 20 years back, you used to have telemedicine room everywhere in all the hospitals, a small space tucked into somewhere, right? And it was never utilized and was used as a conference room most of the time. But now telemedicine has really picked up for consultation and everything. How about you, Mr. Khanna? I mean, what do you think about the same? Because you both are from the same background per se. What are your views on the same? How do you see the technology impacting? How did you at Hinduja, kind of transform the facility for the pandemic?
Let me answer your second question first. That what we did in COVID, I personally think we did not even imagine that we can do it. Like converting the positive pressure into negative pressure in 24 hours. Otherwise, it will take a month for us to do any infrastructure change in the hospital. To do things which, to make an ICU, it would take us 4 months. And we made COVID ICU within a week. So things happened. And now that we've learnt it, I'm not willing to go back there. So we've done a lot of changes. We've learned how to do things. But I'm going to take a little cue from what Dr. Chandrasekhar mentioned earlier. On the design of the hospital, and what I have been seeing, and Dr. Roy mentioned it, that every 10 years it changes. The hospitals earlier were designed because the doctor is providing a service. So you have his office, you have a clinic, and you have a seating space, and you have 5 doctors sitting, and there's a huge seating space. That has now changed to patient demanding care. So that means you need to have for example, I'm giving you OPD, that you have a patient seating area and doctors could be in a different manner. So there's a different way of looking at how OPD should be designed. Example of being with the nature, how nature helps healing. In our ICU, so we are fortunate that east side is the sun and west side is the sea for us in the hospital. So we've got green artificial grass outside the ICU windows. So when patient or the relative, if they open their eyes, they see greenery. On the other side, they see the sea. So it helps a lot in healing. And you have to think of all those things while designing. And we've been thinking, even while we were designing for COVID, the way we designed the COVID wards. It's a small thing, very small thing that, it is a general ward because that is a time you need numbers. So to design a general ward, also you can do it with a little more finesse. For example, you can put curtains all around. So we've put curtains. So there is a privacy in a general ward. And you do it, and you have to think of, which I had not learned many years ago, that the compromise which we make, means I'm talking about hospitals, is that we don't have space. So we'll tell somebody like you that can you fit in 5 more beds here? Can you do another 2 here? So the problem is the casualty of that is the consultants don't have effective space to work around. So when you look at design of a hospital, you look at patient, you also need to see what the doctor can do. I mean, if he has to give a CPR, he needs a space to do it. So you need space for them. You need space. Other important thing now is for the attendants. Traditionally, we have never cared about the attendants. I mean, we have, but in the sense, now it is much, much more. So for example, in COVID, attendants cannot go to the COVID ward, they cannot meet the patient. So first time we've had iPad with the patient, iPad with the relative. So they can talk. So it's a small use of technology. So those are the architectural changes. But coming to digital adoption, so I am in complete agreement that is the way forward. However, I would just like to give a word of caution that digital, in my view, is exactly like a book and a writing pad and a pencil. It is a tool. So earlier we used a paper and pencil to solve a problem. Now we are using a digital technology to solve a problem. The issue is when the people who are giving digital solutions assume that that is the solution. That is not the solution. That helps me provide a solution. So that has to be important. Just because it's a great technology, I love it, it doesn't mean it will work. So that's first thing. Second thing is when the patients are now, see patients, all of us, we are all digital savvy in the sense he talked about the phone. We can book our tickets on the movie tickets on the phone, and we don't, like I came on the flight, didn't print a boarding pass, nothing, you just walk in through that. Patients want that. They want the records on the phone. They want to see so like for example, yesterday, a patient, I'm giving you a small example, a patient got in Vashi, New Bombay area. So he went to a very large hospital over there. For some reason, he was not satisfied. So he came to our hospital. While he was in transit, he sent the reports digitally. Our doctors had seen it. When he reached the emergency, our doctors had seen it, they went, attended to it, and so on and on. So now this was not possible earlier. Otherwise, this fellow would come, we will wait for 3 hours for the test to come. So that's an example. And the last thing I want to say about digital is that there is a cost to everything. And I was telling some of the people I met in the afternoon that we love technology, I would love to do it, but somebody needs to pay for it. So right now, my biggest capex budget in the hospital is IT. And that bothers me because I'm not spending on medical equipment, I'm spending on IT. And IT, for some reason, every 5-7 years, end of support, replace server, replace this, replace that, replace. So the IT costs are increasing. So unless I can get some tangible benefit out of it in terms of increased productivity or increased better patient care, and if there is a way for somebody to pay for technology, adoption will be very, very difficult. Hospitals and healthcare as a community, we are very, very conservative. We are late adopters in everything because we want to first see that it has worked elsewhere and then only we'll adopt. So by the time it reaches us, I hope there are many people who have solutions here, is that what can it do to me in providing patient care? So that I think should be kept in mind, Manu. I'll stop at that.
In the last discussion, there was a discussion happening on the home care. What is the impact of that on the physical infrastructure you would see? I mean, as AI is and digital is going to have a huge impact on the infrastructure part of it. What is your take on that?
So home care is something I've been in love with for last 15 years. So, okay, I mean, so we've had home care for a long time, and and I've seen many home care companies, some have scaled up, some have not scaled up. The way for future is that home care cannot be a service provider for an attendant. An attendant at home doing home care is okay, just a little 10 to 20%. The real home care is, which we talked about, that a patient after he or she is discharged, can we continue some part of the recovery at home? Can we monitor their vitals? Can we convert what we are doing sick care into preventive care by home care? Can I use, there was an example earlier talking about geriatric care. So the senior citizens, they don't need to come to the hospital. Can I monitor them there and provide home care for them? So if I have a combination of nurses, doctors on call, maybe some physiotherapists, and of course, for phlebotomists and so on and on, then the home care is very effective. But if I have only attendants who will go and lift them up from the bed and go to the washroom and back, that's very good, it's needed, but that's not going to be the future of healthcare. So the hospitals and home care companies have to be integrated together in understanding that this is a solution I'm giving for patient care.
Dr. Roy, what do you think about this from a geographical perspective? Do you see any shift in the east and western part of the country in terms of home care?
Not at all. Home care is a extended care. What Gautam is saying, that's absolute. I'm not providing a maid. I'm providing care. And home care is required everywhere, and that's the only way. Today we have 100% occupancy, we have shut our ER. We say we can't take any more patients. And out of 7, 3 of my hospitals have ER shut. At this point, as I'm talking to you, I just thinking, I said, don't do that, but there's so much pressure because especially with longevity, age going higher, and disease, lifestyle disease becoming so common, Parkinsonism, the dementia, those are, and then falling sick. And so I think home care is something which, as Gautam also referred to, we don't see enough people getting into that segment and getting that segment truly as a home care. They're all providing maids. But if you really extend care, then you can really bring 10 to 20% of patient out of the hospital. That means we can provide a true care in the hospital.
Shamit, see, I mean, being an architect, we in last 2 decades, we have always, whenever we designed healthcare facilities, we've been only talking about the value-based things, which comes out of efficiency, which comes out of more number of beds in a given area, and probably, I mean, the thoughts of giving care to the attendants, visitors who are now well-traveled, well-versed with, what is happening around the world. What are the trend changes which we are seeing between the hospitals which were done maybe a decade, 2 decades back and now?
So, providing medical care to the patients will always remain the primary focus. How you can do it better, so that is the areas of focus. In terms of trends, a lot of hospitals now are going for accreditation, be it NABH, which is the Indian accreditation system, or certain hospitals who cater to international clients, they go in for JCI accreditation. Most of these accreditations are SOPs which hospitals follow, where architecture as such is not concerned. But the 10% of the things that are involved in getting the NABH accreditation, once constructed, cannot be changed at a later date, or it's very difficult to change at a later date. So as architects, when we design buildings, we have to ensure that all the needs of accreditations are met with. So this is one area where accreditation is happening, and not only private hospitals, but also government hospitals are now going in for accreditation. It makes business sense also because you get a lot of empanelments to a lot of organizations, and they recognize you for a certain standard or certain quality of service that you provide. Another trend that we see in terms of designing is a lot of stress is on ambulatory care and daycare surgeries. Wellness, as Dr. Chandrasekhar pointed, is becoming a major driver. So you are going in for daycare surgeries, shorter stays. So that is another thing. Another aspect that you see at a larger level is the hub and spoke model of hospitals. So you have in metro cities, you have a major super specialty hospital, and they are setting up satellite centers, 100-bedded centers in, say, 250, 300 kilometers away, which increase their outreach for that hospital, particular hospital, get a lot of patients in these satellites, and complicated cases get shifted to the main metro level or super specialty hospital. Green buildings, as green hospitals, as we call them, are another trend that is being adopted. It doesn't only make social sense, it makes economic sense also. You're saving on energy, you're saving on water, you're saving on running costs. So green buildings are, a lot of hospitals are now actually asking for the buildings to be made green.
I think in government setup, it's mandatory now.
Government is mandatory. I think way back in 2010, they made it mandatory that all government hospitals have to be at least 3-star GRIHA rated or gold rated by IGBC. So that is another push which is coming. And even in the private, because the extra cost that we used to think is now barely down to 2 or 3% of the overall cost of construction. And then year on year you are saving. So that is another thing. As pointed out by others, infection control is becoming a very important factor now. Moving from positive pressure areas to negative pressure areas, using UVGI lamps. Our friends from Blue Star will, I'm sure, highlight on those issues. So those are things where trends are changing in terms of hospital design.
And in terms of, again, evidence-based design, how do you address that in your project?
So evidence-based design is basically research on how patient outcomes are improving. And as rightly pointed out by Dr. Chandrasekhar, connect with nature, use of natural light. So, and the example of Amitabh Bachchan is a very clear example of how the patient's mood and his general attitude towards recovery improves, and the recovery is much better. Another few points in terms of evidence-based design is good acoustics. So noisy places or hospitals, you have beeps, alarms going on, and a good night's sleep is something which is very important for a patient to recover. So when you're using ceiling tiles, because mostly we have ceramic floors and ceramic tiles which bounce off a lot of sound, so good false ceiling system, Naresh would maybe able to highlight on this, good NRC valued tiles can be used. Then you have patient safety, which is very important. Making the patient feel secure, use of grab bars, use of side rails in corridors. So how do you make the patient comfortable? And in terms of healing environments, how do you create the hospital as a healing environment? You create healing gardens. You introduce, as Mr. Khanna just pointed out, his views to the sea and artificial grass on the other side. So how do you make the environment pleasant? So, and these are studies which have been done which highlight that patients have recovered much faster because of such environments. Good signage systems. Patients and attendants get lost. Hospitals are complex buildings, and you usually get lost if you don't have a good signage system. So these are certain items under evidence-based design which have taught us how to improve our hospitals.
So I think, I mean, I get the message very clear that more and more designers and stakeholders are talking about biophilic designs, taking it forward to salutogenic models where it's not only connecting with the nature, but other parameters of wellness as well. So Naresh, I mean, coming to you, in terms of, in most of the buildings, whether they're green buildings or otherwise, I mean, we are all talking about low E glass, air quality, indoor and outdoor air quality, talking about, various, low VOC paints and all of that. Noise, as Shamit very correctly pointed out, noise and acoustics is something which is, I still feel that is left out when it comes to healthcare facilities. They tend to be very noisy, people are under stress, it leads to a lot of stress, distraction to the caregivers, patients, and not only that, I mean, it has the probability of leading to a lot of errors. So you as the product head, what do you think? You have some new materials, something. How do you propose to address this with the designers?
Yeah, so very important, and thanks to both of you as an architect, really being sensitive about this. I can say sound is never been considered while construction of a hospital or an education facility. And that you can close your eyes, you can't close your ears. Sound affects us cognitively, behaviorally, psychologically. So productivity, efficiency, focus is a first victim of a noisy nurse station, or that AHU making noise penetrating into sleep areas, or a corridor being so noisy that any movement happening at night can break the sleep.
And by the way, most of the designers end up putting AHUs right over the nursing station for saving the space on the floor.
Exactly. Yeah, and before that, what we need to really decide as a community to make our hospital building the best building in the city. And that is something we owe back to the entire nation, because anything can happen to the city, any other building, but not the hospital building. Probably that's where we need the hospital building functioning when everything goes wrong, and we know what is happening around. What we fail in wave 2 is infrastructure, gas and oxygens and stuff like that. Modularity, adaptability, changing infrastructure, and we cannot have a hospital with last technology. We have to have a latest technology. How do we really achieve it? How do we really select the material mindfully that it is not spreading infection? I give you a simple example. People are worried about water leakages and AHU wipe and all those things. So people shift to a metal solution.
And that's very evident in government hospitals per se.
I've been to AIIMS Rishikesh and I was crying blood tears looking at a fair of my ceilings, the way it is looking at, and I have a shameful face in front of authority. The way they have treated the material, the way they have used the material, there is a new way we can approach it. A perforated metal is something which you cannot use with negative positive pressure, dust and bacteria getting into the hospital, and we have hospital built, and we need to change it sometime in this country. And I've been speaking about it last 8 years. Second thing, people are putting stone, people are putting cement sheet, calcium silicate on the head, where a seismic movement can, break a head of Damini dialogue, 2.5 kilo ka haath. People will actually get injured which are not moving. Fire is another issue, seismic is another issue. The entire construction of the hospital, we compromise on the building without really knowing that this is the building which is built for next 50 years. Now, next AI movement is around sound. We need to really monitor the patient, we need to really catch all the voices. Where do we have that faculty in our hospital? It is more noisier than Mahim Market to be in your hospital, And it is so, you have 75 decibel sound happening in the common corridor, same sound is traveling passages, going to the patient room. People are struggling with critical decisions and you are surrounded by so much of noise, you feel stressful. That's a natural consequence unless you are a sadhu, you are not. So entire patient care, the length of stay is increasing. We are talking about having more number of beds, but can we really make our patients sleep and recoup quickly so that we can reduce length of stay, have more patients served, and actually making patient-centric designing, or doctor-centric designing, rooms for privacy, rooms for healing, rooms for communication, need to be designed with different material. Most of the hospital, even if it is my specification, it is the same product for 40,000 square meter. It is very evident that we haven't paid attention to the need of that room for privacy, need of that room for voice clarity, need of that room for no distraction from outside. Now, these are the basic elements when we are moving to a higher technological adoption for human-centric, human productivity, human performance. Performance of the doctors, patient are two different aspects. Doctors are using it for 365 days, patient only for 8 days. So can we make doctor-centric, nurse-centric designing?
I think it is wellness of the occupants, right? Irrespective of what role they are playing in the facility.
I'll just add to this. Take a typical case of ICU. Our people are like Arjun. Fire fellow will only look into the fire aspect. He says, "Ye nahi hona chahiye," the kind of a sanitizer and etc. you're using. You have seen the number of fire incidences in our hospital. Air scavenging is part of it, which is not done. Sound is only sound related issue. It has to have a comprehensive approach. Monitors will make noise because it has a relationship with the alertness for the nurses, etc. How we adopt and try to work it out, when we try to work it out a separate cubicles and work it out a space, then the investor says, "Arey, instead of 15 ICU, can I have 20 ICU beds in that so that my return on investment?" These are very common complicated challenges. One has to think a comprehensive approach and then arrive at. That's, I just gave you one example, and similar thing happens at various level because everyone is looking at a different perspective. Clinician will look his comfort, the nurses will look their own comfort. That is why medical architecture is the synergy of all this and try to achieve and arrive at. I always give one small example. Location of a sluice room where bedpan is clean. If you ask a nursing person, she will say near the duty station. If you ask a public health engineer, he'll say near the toilet because he is concerned with the disposal. If you ask an administrator, minimal travel distance because before the patient defecates, that thing should be given to him. Such things are, everyone has his own way of expressing. That is where one has to have that synergy.
So, Naresh, hospital-acquired infection, which we just spoke about, right? I mean, that's something which is again catching up. I mean, it's probably in our country it's not recorded too well, but if you look at the Western countries, I mean, hospital-acquired infection is something which is taking more toll for the deaths, right? And have you come up with something? I mean, I saw a presentation running with UV tiles or something. So I mean, do you have some products which kind of address that to some extent?
So we come up with a LED-based solution which clean the air at a time of delivery. So instead of putting something in the back end, we are putting at a delivery end. So the fresh air, clean air is coming every single time you use the facility. Plus the products which we have for healthcare, which is like a 6 surface, is antifungal, antibacterial. So there is a range of products which is called BioGuard range, from RH100, water resistance to acoustical nature and a metal solution. Everything has a BioGuard range. So combination of a surface which doesn't allow any colonies or anything to grow onto it is permanent solution because it's silver ion based technology used there, and using active cleaning technology for the air with a UVC based retrofit. It's not a solution for the entire hospital. It's a very tailor-made systematic solution for niche area where you have more traffic, proper use. So it works in tandem with traditional system with a new system combination. It complements and make the hospital ready to be used in retrofit manner. It's an exciting solution which will transform with no cost, no intervention, plug and play, very simple product which will transform places in no time. Like we're saying, we don't have time, but we can just plug in power and that air is clean in that area.
Bhagat, coming to you, I mean, I know you've been patiently waiting, right? HVAC plays a very vital role when it comes to hospitals, whether it's about filtration, because of the pandemic, various, air changes, air quality. So what are your thoughts on the HVAC per se post-pandemic, how your products have evolved?
Just give me a minute. I just want to step back a little. I was just hearing about positive pressure, negative pressure. We from Blue Star, we cater across the length and breadth of the country. And prior to pandemic, we have had a lot of installations, hospital installations across the country, including the Apollos and the Hindujas and all the big names. What I want to say here is, prior to pandemic, even this, I have not seen in most of the hospitals, especially in Tier 2, Tier 3 cities, this differentiation of the pressures itself. I have seen a common air conditioner running across the whole hospital. There have been many hospitals like that. There has been no pressure differentiation. The same air goes to the operation theatre, the same air goes to an isolation room. I mean, that was the situation. I think we need to be realistic of where we stand. I think the references cannot be restricted to these hospitals who probably have better knowledge. That's where we stand. I think we have a lot of way to go actually. I think so there was a question as to how to convert positive pressure to negative pressure. It's very simple. It's just to do with the air changes, what you throw in and what you take out. It's as simple as that. It can be done. Sir mentioned about the noise levels. Yes, we have been asked to install. See, we don't prefer. We just get instructions, right? So we have been asked to install an AHU right above the operation theatre. There have been many instances. These happens especially in tier 2, tier 3 towns, I'm sorry to say, where the decisions have been made by the doctors themselves. No architects gets involved. That's the reality. So I think as I said earlier, we have a long way to travel. This is what I thought I'll just share here in this forum. I think we think that we have evolved, but then there have been many areas in the country where the evolution has not happened. That's a sad part of it. So, as I said, so as far as the air conditioning is concerned for a hospital, so that's why I just want to go back to the basics a little bit. Most of us may be knowing, but I just want to go back to the to the basics, which probably we have forgotten before pandemic. As you rightly said, everybody is concerned about the efficiency, FSIs, how many beds. A typical HVAC system has to take care of the thermodynamics, which is basically the temperature, comfort, and the humidity, which can happen through the refrigeration system. Sometimes it needs an augmentation to keep the humidity constant. Where is no such thing happen? Okay, and the pressure levels, which we have talked about, the gradients of pressure level between these things didn't happen, and the filtration levels sir mentioned. I think there was no consideration for filtration levels. Forget about the ppms and all that. There was no consideration of the filtration levels, and the ventilation was completely forgotten until COVID came and stuck. There was no ventilation. There have been installations in the hospitals where there is no provision of air exhaust. It has to exfiltrate somewhere. That's all. So that's the scenario. So I just wanted to touch base on these points, which probably has come, to everybody's senses, but I think we have a long way to go. And I think way back in 1980s, when somebody approaches for a hospital air conditioning, that is directly dealt by us. We do the design, so we take care of all these things. We know where to keep the air handling unit. We know how to keep the ducting. So this is one part of it. Other thing is post installation. The duct is forgotten. Air is passing through. Fungi is obviously going to develop. Completely forgotten. So that's the reality. So a typical, coming to answer your question, I think I just migrated a little bit. To answer your question, these are the things which need to be taken care. Basically, the thermodynamics, which is the temperature and the humidity, filtration, and ventilation. Of course, the pressure gradients, which is very simple. For a HVAC engineer, it's very simple. It's not a rocket science. It can be done. Only thing is, if it is taken care in the design, it saves a lot of time and energy rather than doing it later on and modification. And instantly, sir mentioned about the filtration. I think when this COVID struck, and then a lot of emphasis came back on us. We were all under stress. We were just going and learning from wherever source was there. I think we could hardly find anything, but we just we could probably any product development takes about a year's time. From the concept to the completion stage. In the COVID circumstances, that UEGA which sir talked about, we just came out within a month because that was a need of the day, So we just had a separate, team working on it, and then we have come up with the UVGI, air conditioner built up with the UVGI, and that's well, taken.
And how effective is that?
It's very effective because, as sir was saying, it is just not prevention; it just goes and kills. So so we in Blue Star we generally are sensitive to the Indian, we are not like an MNC kind of a brand. We know the physical and the, geographical needs of the country, and we, just to little bit on the company, we always happen to bring in technologies to India. That has been our strength. Whatever is the new technology which is going to help the society as a whole, we just bring in. I can have so many examples. We always strive to bring the technology to India. So that's the answer to your first question, that yes, we are very well aware of the needs of the air conditioning system. Only thing is, if you are allowed that freedom, I think we can design and offer a very good HVAC system to the hospitals.
In fact, in some of the forum, some people asked me, sir, you design big hospital, just tell me my people who are running a nursing home in small garages and all, how they should handle the air conditioning system. I said, first of all, in my principle, your window type air conditioner is never ever given okay. No, sir, you have to give answer within that what we can do. That is where these people came up with, kill it. If you are going to trap and recirculate, don't recirculate, kill it. We have to find a solution because obviously these things emerges out of the basic needs. Please.
True. So, Bhagat, are there any technological improvements that have happened over?
Yeah, sure. See, I think the last part was more to do with the design. I think the next part is very important.
I would also connect it with IT and
Sure,
other.
I'll take it in two parts. The technological improvements will have a direct impact on the operating expenses of the hospital, which in turn will have a net effect on the cost of the patient. So as I was just telling to your earlier question, we bring in a lot of technologies to India. There has been a lot of technological developments that have happened in the HVAC industry, like similar to any other industry. You might have heard that inverter, that is cutting across all industry. It is, it's going and having its impact because it just saves on the operating costs. So we have a whole lot of equipments. In fact, more than 80% of our air conditioners are inverter driven, right from room air conditioners to the large chillers. And we have even better technology, like the HVAC system is basically running on a compressor, and that compressor needs some lubrication, in simple words, and that lubrication needs some energy. So we have brought in a technology where the compressor doesn't need a lubrication at all, what we call as oil-free chillers. So that is the highest end where it is very efficient, because in any hospital, you will all agree that 50% of the energy consumption is on account of HVAC. So the more you save in the HVAC system's energy, the direct saving is on the hospital running. And there has been, like as I said, these are the technologies that we have brought in, which has really helped not only hospitals, across all industries, especially which are running 24/7. So right from a small scroll systems which we introduced way back in 2000, from there onwards our journey starts. We bring in a lot of new technology, and in the large hospitals where chillers are installed, we have migrated the whole design concept at all. Like in Blue Star, earlier we used to have some select machines, for example, from say some 100 ton to some 500 ton, I'll have some 10 machines and I'll try to fit in, within what I have. So we have completely changed that concept itself. Now, whatever equipment we design is tailor-made for that application. So exactly the performance is made, and there is no kind of oversizing or undersizing. So this concept itself, we brought to the industry. And along with the technology, this entire tailor making of the equipments adds to the efficacy of the air conditioning equipment, because we need to be mindful. It is not about the efficiency when it runs at its full capacity. Most of the hospitals are going to have varied loads. It may be running in the lower loads in the night. It may be running at full loads probably in the around 10, 11 o'clock in the morning. So it has to be efficient all through. So that's how our equipments are designed. So we can share separately, about our, benefits of our equipments. I don't want to talk more about our company itself. And just another point, one is from the manufacturers themselves, like companies like us who take the lead. And I have to appreciate the government of India. They have taken a lot of strain. They have been largely kind of passive all these years. Now, in the last maybe 2 years, just prior to pandemic, a lot of regulatory implementations have come. Like for example, we all will be seeing that star label. Whatever. So if you buy an air conditioning or a refrigerator, you'll be seeing a star label from 1 star to 5 star. We all know that 1 star is probably low cost but high efficient, and 5 star is vice versa. Government of India has implemented this labeling program for the highest equipment, highest HVAC equipment of chillers, which was never dreamt of. It has happened in very few countries across the world. I think India I'm happy to say that a lot of developments have happened, and then it is going to be mandatory from 1st of January. So any chiller which is bought or sold has to have this labeling. And that labeling, what the government of India has done is, see, most of these equipments gets imported through some MNCs. And the equipments manufactured by MNCs are not based on Indian conditions. Indian conditions, we all know that it is, high ambient conditions, not so very good quality of air and water we have. But then the equipment that get imported are designed for some European and American conditions which are far better. Okay, so government of India has taken cognizance of this, and they have instructed the manufacturers that you have to tweak your design to suit the Indian conditions. Because whatever efficiency I declare should be for the Indian conditions and not some American or US country. It doesn't make any sense. So government of India has done that. This chiller labeling program has taken into account that all the equipments have to be manufactured as per Indian conditions, and the efficiency is same way from 1-star to 5-star. It is branded. What I can happily say is, as Blue Star, I think we have taken the lead. We are very much ready. I think it is January is another 5-6 months down the line, but we are already ready. We have got our equipments already 5-star rated. I'm happy to say that. I'm sure all other manufacturers also will do, but then we have already taken the lead. We are fully ready. So both from the manufacturer side and the government side, I think we are going together. This has never happened so far. I think this is going to be very positive. That's what I expect. The other question which you mentioned about the technology and the IT and in large hospitals, it is very much impractical to expect that all the equipment to monitor whether all the equipments are running at its design condition. There are some air handling units. So it's very difficult because people cannot be going up and down to various places, and it's very difficult. And hence, we have made our, for example, chillers and VRF systems, everything. We have made our equipments to be compatible with the building management systems. So what is the operating condition, for example, of our VRV and chillers, can be directly hooked to a BMS, and the chief engineer, for that matter, of a hospital can see the performance himself sitting in his place. He doesn't have to depend on some of his technician to come and see. He can see within himself. So that's an advancement we have already built in, that the industry as a whole has come. We have gone one step further, and then we said it is not just about monitoring. We have to also have the correction happening immediately. For example, some chiller is not running. There is a problem there. Right? One is knowing the condition. Other is the making the correction immediately as far as possible. So what we have done is, and we can't depend on the hospital technicians for that, right? It needs the expertise of the HVAC guys. So what we have done is, we have introduced a system called as a remote monitoring system, where we connect our chillers to a centralized, chillers or VRS, whatever, to a centralized remote monitoring facility, which is supervised by experienced engineers from our company, 24/7. And we have made this technology simple. It's not going to be costly for the end user. We are mindful of that. It is just taking the data through cloud and then taking it back to our remote monitoring system. And then they'll be monitoring on behalf of the customer. We'll be monitoring the health of the equipments. And not only it stops there, in case something goes off the curve, then the whole communication channel is activated, and whoever is the technician in charge of that hospital, 24/7, anytime during the day, he gets an alert, and then he can go and rectify the system immediately. So this is another thing which we have brought, all based on the comfort which we get from IT. I think this is what
I think we've already overshot our time. I'm getting.
That's why I stopped it in between.
So house is open for any questions, or we can connect actually offline, post the session. Sujata, so
Good afternoon. Myself, Pankaj Kumar from Blue Star. I'm taking care of designing in our company. So my question is to architect. So normally when you see that any hospital while designing, we don't give a preference to the services. We always keep into the corner. We keep a space, give a space for equipments in a very less space where we design or try to fit to our equipments. that's probably give a unhygienic to that whole hospital. So what kind of a thought we can put, at least we can give a preference to those equipment which is required to run a hospital. Because see, any apartment if you go, you will find it known because of its amenities. Similarly, the hospital also known because it's got a good hygienic, everything is there. So that's a very important part of it, which probably we are not giving a preference to those services. That's what my question is to architect, that how we can think of those to give a preference.
See, I'll tell you, I mean, as I was talking about, we have been, actually the hospital design was always focused on efficiency-driven things, and services were some part of it which were compromised, and you have ceiling suspended air handling units and stuff like that. But I think over a period of time, even the promoters have understood that it is equally expensive to run a building like a healthcare building, which is not adequately supporting the services, because they're highly engineered buildings. These are one building types where the promoter actually lives with this building. They're not selling it up and going away. So the maintenance cost kind of goes up. I think there is a shift as far as the design of the healthcare facilities are concerned, wherein the designers, the promoters, everybody is understanding the nitty-gritties of engineering and are providing adequate space for that now.
In fact, Mr. Bhagat informed about the use of automation and maintenance, how it has to be. I'll just give you an example. AHU room, the person who is operating, he sits and has his lunch drops there, rodent goes around, one side you are having an operation theatre being served by that AHU, and now you talk about infection. That is where automation helps. And now, the space-wise, as he mentioned, things are changing. Yes, a maintenance person will always feel a crunch that there is no space given.
So usually what happens is when you do a basic design, one of the people you consult is your MEP engineers or your MEP consultants. Because without having the services being fitted in properly, without having adequate space for services, your design is not going to function. The moment you lose out space or you leave out spaces for AHUs or electrical rooms or other services rooms, at the end of the day you will have to provide them. So it is best to consult it at the concept level stage itself, at the preliminary design stage itself. All these services, you take inputs from all your consultants. Healthcare is something which is not a single person's design that can go through. It is a huge number of people, consultants who sit together. It is a multidisciplinary approach. You have architects, you have doctors, you have administrators, you have nursing staff, you have engineering staff. All their inputs come into it, only then can you create a successful hospital building.
Sorry.
So you'll find no space to run around.
So
the services are scattered here and there.
Service floor is an issue which is actually coming from, height of a service floor is from municipal bylaws. So it's either you lose out on FSI, you create a proper floor, or the municipal bylaws restrict. Some places it is just 1.8 meters. Some places it is 2.7 meters. So what the municipal bylaws permit you to have is defined by, not by the architect who gives a 1.8 meter height space, but that is what the authorities will permit you without counting it under your FAR or your FSI. Otherwise, you have to lose out on effective space.
The space may be coming free of FSI, but still there is a cost to it.
There is a cost to it.
So
Of course, but this is also
Can I just add?
this is also important aspects to think of.
Manu, I have a question right here.
yeah, hi.
And not a serious question, and I've been following you for a long, long time, and you really champion the healthcare space as a vertical, as one of the most marquee designers for the country. You've done so many hospitals, and as I said to the audience, it's not going to be very technical because A, for nuts I can't. B, I just wanted to put a lighter perspective. Which is, since you've done so many hospitals, which is by far has been the most, favorite of yours, and why?
Most fairly?
Favorite of yours, and why?
So you see, I mean, we are doing a lot of projects. I think we have recently completed a project for Apollo in Lucknow, and I think that is kind of,
the next one.
from my standpoint, that's my best design we have done in the recent past it's a crux of, you know, whatever 20 years of building hospitals. It's a very good mix of being cost-effective hospital in terms of building the hospital. It has been aesthetically pleasing enough that it is catering to the needs of the, you know, millennial population in terms of having all kind of IT infrastructure and all of that. So that's what it is. I don't know if I've answered your question.
No, that's perfect.
I wanted to just add one point out here for services, because it is unpredictable, constantly changing, you know, life to death situation in a hospital, like it's a live body, you know, 365 days, 24/7. So we come up with a corridor solution where you have maximum services running, require augmentation, maintenance and all those things. And the inspiration came from here, you know, some 8 years back. And this solution is launched called FS600 corridor solution, where you can swing the tile and move it in one direction. No suspension taken, only support from the wall up to 3 meters. Now, those kind of innovations will allow you to fit in services in our own ways, in our own areas. And each area need to really augment and innovate constantly. Like he says, which is the best hospital? Next one. You know, for architect, it's always constant creation, and the next one is always the best one. You know, yet to come kind of stuff. So we are all work in progress, but such solutions are available. AHU solutions are innovated. We are constantly improving. And that's the hopeful place. Yeah. Correct. No trap of a trap door. Everything is open.
Tilt and turn and slide.
Yeah.
Do your job, do this thing back.
So we used to do it for airports and metros and all. So with his guidance, we introduced into the hospitals now.
Good afternoon, sir. May I?
Please.
I am Deeptendu. I am from Narayana Health, Delhi. Nowadays, the most threatening part to a hospital administrator is fire. And the most of the incidents that happen due to the HVAC system only. And the past incident, AMRA case has also happened due to the HVAC system, blockage system also. Sir, my question is to the entire panel. How the digital platform can prevent that kind of incidents to a hospital HVAC system and make the system in robust way, so administrator can sleep little bit stressless in night. So one is the remote monitoring system which we have. Another is there any other technology or methodology is there to monitor the system, the entire firefighting system, to take the control as an administrator in the hospital?
Yeah.
The BMS is what it is. Just now he mentioned that in sitting in one room in the central monitoring system, he can control everything, not only there, even from the remote. So there are various type of things are available, only it adds a cost. You have to pay for it, everything is available. In digital platform, the only way how you manage your water supply, your electrical, nowadays they have gone up to the extent of mobile app. I can switch on my generator from my app, I can switch off the electricity, everything is possible. But provided you have to, and now you know that everyone has come up with a smart switch at the home also. So these are all available, and digital platform is the best platform which has helped us, lesser manpower, more efficiently, and I can get alert, which is more important. If you want to add anything.
So just to add to what sir has been saying, I think a direct answer to your question is yes, air conditioning plays a very major role in case there is a spark somewhere, and for that spark to spread and make a big fire, air conditioning does have a major role, because the air conditioning ducts run all across the hospital, and it carries the fire along with that. So for that, what we do is there is a fire damper, what we call, we install in the duct, that basically comes into play whenever there is a fire. Okay. So what the damper does, it's like a flap, it just closes the duct, whereby the air doesn't pass through further, and then the fire also doesn't get spread. So that fire damper, okay, which is a mechanical item by the way, can be part of the building management system is what sir has been saying. And for that, one need not be there in that presence. The whole fire can be controlled sitting elsewhere in the hospital or even outside the hospital also. That's a technology available now. All one needs to do is link that fire damper to the centralized management system, and then the control shifts there. And then the moment it gets closed, obviously the spread stops. It's as simple as that. Only thing is people have to be aware of that and then implement as that.
Basically, you need to have a good MEP consultant who designs and locates these fire dampers at the spaces that they are required. There are fire bylaws which talk about compartmentation. So if you have to compartmentalize a fire and control it, you need to have fire dampers in those locations. So once a fire is there, the damper will get activated, shut off the air conditioning in that area, and the fire can be contained to a certain area. And then you have fire sensors, you have fire detectors, alarm systems, all connected to the building management system, and which will even tell you if the sprinkler has gone off or not. So the technology is there, and as Dr. Chandrasekhar rightly said, it comes at a cost. You want to give your stress away, you have to pay for it.
I think we are overshooting
really
our
crossed
time.
our time, right? I mean, Vibhor,
Yeah.
I think it's over
So
to you.
organizers are restless now. Let us.
No, I think it's not restless. I would love them to devour the session, but in the interest of time, and I think a big round of applause for the lovely panel. How design infrastructures are very close to our heart. I think they form the bedrock of any successful building. Why healthcare everywhere? And I'm just filling it up for my editor, Sujata, who's been actually speaking for a while, and she needs some rest. And my name is Vibhor Srivastava. And may I call upon Saurav Das, Head Projects in Hospitality South Asia, Hafle, and Shraddha Sumani, Director Key Account Management Lead Squared, to come up on stage to felicitate our esteemed panel.